voice clear at least?
Yes, the voice is excellent. Thank you. Okay, excellent. So welcome everyone. This is the fifth time we do this. I mean, people like it, so thank you very much, Delicia, for is it Delicia or Delicia?
It's Delicia, but I
Delicia.
answer to everything. So
That's fine. That's fine. So Delicia is MR consultant at Sherwood Hospitals, and thank you very much for joining us. Can I start as usual to ask you how you started this sort of pathway? When did you start it? Take us through it from the start.
Okay, thank you, Mustafa. Thank you very much for inviting me to share my experience. I've been in this country for about 20 years now. I graduated in India. I finished my MBBS in 2000, and then I did my diploma in ophthalmology again in India from Aravind Eye Care Systems, and then moved to this country in 2004. Started as an SHO in 2006, and at that point it was the membership exam of the Royal College, which I then passed in 2008. I then took a short career break because I had my son, and then joined as an SAS doctor at Sherwood Forest in 2010. So I've been an SAS doctor since 2010 up until last year at Sherwood Forest Hospital.
It's a long time.
It is a long time, and because my husband was also training, he's a consultant in A&E now, but he started off his A&E training, and I had a small child, so obviously very happy with my SAS post. I was quite satisfied working in a decent unit. I was getting one
specialty doctor, correct?
A specialty doctor, yeah. I was getting one theater a week, one laser session, lots of glaucoma and medical retina. So that's all I was doing for many years. And then in 2016, the college said that I don't know if you are aware that the membership exams finished, and then they became the fellowship exam, the FRC off. And the college had an agreement that if you had your membership, you were exempt from part 1 of fellowship and the refraction certificate, and you just had to sit the part 2. So they were stopping that exemption in 2015-16 time. So they kind of said, if people are not taking their FRC off by this particular time, you will then lose that exemption that MRC off gave you. So I was kind of forced to write the exam, let me be honest, because I didn't really have a plan of doing it. And then I gave the exam, and thank God I passed it in 2018. My husband was coming to the end of his training and his fellowship. So I was kind of mentally thinking, well, in the next couple of years, I should start my CESR journey. But unfortunately, COVID happened. And when I approached the university hospital, which is Nottingham University Hospitals for us, the clinical lead at that point basically said, look, it's COVID. We are not we're not encouraging any new doctors to come into our hospital. So I'm really sorry. So everything was shut down. My department, they have been supportive, but not in the beginning. Only the clinical lead was willing to even entertain this talk about taking some time off to do CESR. The rest of the consultants were not supportive. But I had to go to the trust management as the divisional director. And then they said, yes, we can do it. And we came up with a plan where I would drop a few sessions of my weekly work. So I dropped about 4 PAs, which is 2 whole days.
Okay.
I didn't have to. I mean, later on, I managed to reduce it to just 2 PAs. And then with my admin time, by then there was a change in the clinical leadership at the university hospital, and they were willing to accommodate me. So I went away in 2022. Yeah, May 2022. I started doing 2 days in the university hospital, doing subspecialty clinics. Mm-hmm. And then by February 2023, I'd finished it all, so 18 months. I was also working.
Was that honorary? Was that honorary? So you wouldn't get paid there?
Well, what happened was it was originally supposed to be honorary. So they said, enroll with our bank. We will keep you as a honorary doctor. But within the first couple of days, they realized that I was quite senior. And the consultant, I started off with a VR consultant, and he basically said, let's use her to help with our waiting list. So let's book patients for her. So they booked about 8 patients for me in VR, 8 to 10 patients. So I ran a clinic side by side with the consultant, and then they paid me the bank rates. So I was continuously paid during this entire period. So though I was prepared to take a pay cut, I didn't need to. So finished all the evidence collection in 2020. 2022 May I started. Sorry, I finished it in 2023 July. So I was in the university hospital for a year and a bit, then came back to my unit. I had to tidy up some more evidence like glaucoma, MR. And then in February 2024, I had all the evidence, but it took me a good few months to organize it. And then in August 2024, I submitted it.
Okay, and you got your reply in
April 2025.
Right, so that's less than 12 months.
Oh, 8.5 months to be
That's
precise.
quite good. That's quite good.
Yeah.
So when you started collecting the evidence, so I assume you've already sort of done all of your evidence previously, and then you just started to write it up. Is that correct? In 22, you were saying?
No, what I realized was, as I said, I've been thinking about CESR from 2020. So 2021, I attended a college CESR day, like what we have as a portfolio day. Now we had a CESR day then. And that's when I realized, for the sake of triangulation, there was no way I could use my retrospective data. It would become very onerous on me. So all my evidence is prospective, except my cataract numbers and my laser numbers.
Okay.
Every other single bit of evidence is prospective.
Right. And so when you started sitting down and writing up the evidence, how long did it take you until you submitted?
When you say writing down, because when you're doing the clinics, you're doing your logbook simultaneously. You're doing your patient list, because we were supposed to do those 20 clinics, so we mentally had this 120 patients per subspecialty that I needed. So that was happening as I was attending clinics. So most subspecialty clinics, you would have between 6 to 8 patients. That's the number they were booking for me, because I was kind of being treated like a fellow or like a senior registrar. So I had, how I had planned it was, so if I did 2 clinics or even 1 clinic per week of a particular subspecialty, I needed to do 20 clinics. That would take me 5 months if I did 1 clinic per week. So I arranged it in such a way that I did 2 subspecialties simultaneously. For example, I did VR and a little bit of neuro-ophthalmology. Then I did cornea and then continued to do neuro-ophthalmology, because neuro-ophthalmology being super specialized, the consultant was only happy to have 4 patients under my list. So it took me a longer time to do neuro. And then I did a bit of oculoplastics and uveitis simultaneously. So this was all just 1 or 2 clinics a week. And basically the agreement with the university hospital was that I would also help in their eye casualty. So
you don't know that, again, casualty, you can get lots of cases from casualty as well. Did you do that?
Exactly, yeah.
Fine.
So,
and was it easy? Sorry to interrupt you with too many questions, but was it easy to get that honorary sort of job at Nottingham? Because lots of people are trying to do that and they found it sort of a bit more tricky in various places.
I think every hospital has a bank, so you need to register with the bank. And then I think you need to negotiate. I think this is where your negotiating skills kind of come into play. And I think I've been lucky because I've been in the region for a little while, so I'm kind of familiar with some people. So when I approached people were quite willing to help as well. And the fact that I offered to do an eye casualty session for them was the real catch. So they were very happy. Even the clinical lead could sell it to the other consultants that, look, she's coming, she's going to help us in eye casualty. She'll help us with our list. All she'll need is signing off a few forms at the end of the placement. So I would discuss with the consultant most of the cases. And because I was very upfront with them right at the beginning that this is what I want, so they knew what they were signing up for. I knew what I was offering. And at the end of 4 or 5 months, I would have my 10 CBDs ready. And I would send it to them. We'd sit one afternoon, go through all the cases. And because I would have told them that I'm going to do this as a CBD, they were already aware as the clinics were going every week. So at the end, I would do the CBDs. And if I was doing any like minor procedures, laser, suture removal, anything, I would get a DOPS done, keep sending them the tickets. But to be honest, most of the consultants, they wouldn't sign anything till about that nearing that end of that 4-month period. And then one afternoon, they'd sit with me and sign everything off.
So they are supportive. They were okay signing you off for whatever you need. Yeah.
Yes, they were quite happy.
That's good. Yeah, I think most people now are more supportive, and things are becoming easier because it's now becoming more obvious and known that there is more support basically. So again, just to encourage everyone that now people are more aware of this process, and lots of SAS sort of leads. Sweeta, obviously, she's really promoting this sort of thing at the college conferences, and so it's getting better, not worse, definitely. And so you got your reply just from first go, and you were granted your application accepted from first go.
Yeah,
Well done,
yes.
well done.
I think, Mustafa, I think for me, the whole point was, I think I kind of got into it quite late, so I didn't want to waste any more time. And knowing how long the process was taking, I wanted to do a watertight, submission right from day one. And after attending one of the CESR days by the college, one of the presenters was a lady whom I had met during my exam time. She was also giving her exam, and she had done it all. So she was like my kind of go-to person. So she sat with me one afternoon, took me through the whole process, and showed me all her evidence. And once I knew what had to be done, it was just sitting down, putting those Excel sheets in place. And then that took me a weekend or 2 weekends to get different Excel sheets in order, and then populated them as I went along. And what I really found useful was the Caesar Made Easy book.
Yeah,
Um,
by
I don't know.
Rams.
Ramis, yes.
Yeah,
And I think that's a fantastic guide.
yeah,
So if you read that, and then the SSG by the college, and the curriculum from the RC off,
yeah,
I think then you get a very, very detailed view of what you need to do. Then you just put your head to it and do it.
yeah. Obviously, you do know that things have changed now, and the new portfolio
Yeah.
pathway and stuff. So it's becoming even easier. Okay, so now the whole idea is it's becoming more lenient. Yeah. So in the past, they used to say you have to do 120
Mm.
cases, has to be 20 clinics. Now it's a bit more relaxed. So that's even better. Even with the new
I'm
portfolio
not
pathway. Yeah,
Yeah, I'm not entirely sure. Sorry, Mustafa. I think because we both are not, you're not able to see me. I seem to be interrupting you. I'm really sorry.
that's okay.
Um, what I think is going back to what you said about how easy it is. I think SAS doctors now have a louder voice. We are more organized as a group. And there are SAS leads within the trust. And it's now almost become a right for the SAS doctors to talk about their career progression. Whereas about 5, 10 years back, SAS doctors were not in that position to demand anything. For example, just last week I was part of the panel for interviewing specialty I had to interview for my own post really. And then I realized that none of the candidates were people who were already in the country. Everybody was, they were from outside the country and trying to get in. And everybody was aware of the CESR pathway or the portfolio pathway, and everybody was asking that as what is the support. So straight from day one, they seem to be clued on into the process. And I think that's very impressive.
Yeah,
And the trust seems to realize that, and they are like, yes, we will. So the commitment is already made at the time of your employment. So
yeah.
I think it's pretty good.
Yeah, it is getting better. That is something that people need to be encouraged about. Things are
Mm.
improving, not getting worse. That's definitely for sure. Whether it's anywhere in the country, it's becoming more popular now. And as you said, it's sort of a right for people to progress because it's give and take. Yeah, so you go, as you said, you're going to offer them something, and they will give you something in return. That's just only fair. And that's for trainees as well, by the way. Do not assume that trainees it's very green on the other side. It's not always like that. Yeah. So again, trainees, if anything, my opinion, actually doing the portfolio pathway or the Caesar is actually quicker than doing the training. Yeah, because if you think about it, if you're senior enough and you've got a supportive team, you can get everything signed off within 3 years maximum. And then once you're
Totally,
done, you can just
totally.
go. Yeah, the
Yeah.
trainees, especially the senior ones, 6 and 7, they have to do lots of repeated rotations just to cover the service. Yeah, so it can definitely be less than that, but has to be in a supportive place. And obviously, you have to be keen and motivated to do the thing. It's not easy.
It's not easy, but again, I mean, you were absolutely right about the trainees, because we normally have trainees that go through our department, and I've seen about 10, 12 years worth of trainees, right from their ST1 to now becoming it's a very hard journey for the trainees. It's way harder, and they have to learn as they go along as well, whereas most of us are reasonably experienced. Even if we start off as a first year SAS doctor, you've already done exams back home, or you're generally you're probably starting at a level of an ST4, ST5 already. And the other thing I would say is in this whole journey, my trainees have been more valuable than even the consultants. I'll have to be honest. They helped me understand the curriculum. They helped me show where everything was. So I actually have to owe it to the trainees who helped me with all of it, actually.
Yeah.
I didn't even know. I would sign off their CBDs and docs and stuff, but I never paid a lot of attention when I was doing it for them. So when it came to fill for myself, I was again back to square one. And they were brilliant. They took me through everything. They showed me their own portfolios as to how they gathered evidence. So very useful. So one advice would be make friends with your trainees. They are your best ally.
Exactly. You have to be nice to everyone so you can get the support back. Trainees, nurses, managers, consultants, everyone. So, and it's a trade-off sort of thing. If they do if you support you in your CESR, you're going to get trained, and then if you like the place, you will become a consultant there. So it's investing their time and money in training someone who's going to stay. So it's just a win-win, I think. Fine. And so let's ask a bit more specific questions about the sort of documents and stuff. So I assume you submitted logbooks. Is that correct? Patient logbooks?
Yes, I submitted patient logbooks. Yeah.
And you were very specific about 120 per specialty.
Yeah, I kind of, in some specialties, I got up to 140. In neuro-ophthalmology, I think about 80, 90, and the remaining I kind of made up with eye casualty patients. So mostly, I mean, I definitely hit 120 in all of them.
Okay.
And some I managed to do a bit more because I do a lot of MR myself. So it was very easy to get 160 or something in MR. And what I did was as I was doing the clinics, I kind of knew which patients would be CBDs. So once I earmarked that patient, then I made sure I dictated a decent letter for them. Quite well planned. Normally, my letters are not that elaborate.
Not that great.
Yeah. But when I first started it, I was like, oh dear, I'm going to have to do this for every patient. But then within a week, I realized, no, I'll only do it for patients on whom I'm going to do a CBD. So for example, in an MR patient, let's say somebody with AMD comes. So I'm seeing them, I'm assessing them. So I dictate the letter about not smoking, nutrition, supplements, everything. And then if I was going to initiate the treatment and do the intravitreal injection for them, I'd get a DOPS out of it as well for an intravitreal and then enter it into my logbook. That way, the triangulation process became quite easy.
Triangulation is very important, by the way, because they need to be satisfied that you've actually done this evidence. Let's be honest. A logbook can be made up because again, people now are using ChatGPT and stuff like that. Anything can be made up, but the only evidence, because you've written that yourself, but the only strong evidence is either a patient letter that will say your name down there. Yeah. That means that you've definitely seen them. And obviously someone who signed you off for something like a DOPS or a CBD or whatever, that's the strongest piece of evidence. Actually, the logbook is the weakest piece of evidence. And someone previously, I can't remember who, did not submit any logbooks. They only submitted patient letters, but again, he submitted lots of patient letters and very detailed, as you were saying, very detailed patient letters, and it worked. So, but the forms, I definitely suggest the forms. You have to do them. And would you agree that, you're doing MR, for example, you are very senior, but still they require 2 DOPs of doing a tap and inject, for example, correct?
Oh, yeah. I mean, I think the curriculum is very clear. So I don't know what everybody else does, but when I attended the CESR day, Robert Hulston, the college, the guy who deals with everything, he gave us a template to work towards. I don't know if I've got all those templates. Would anybody be interested in seeing?
Everyone has got them. Trust me.
Excellent.
Now, yeah, things are now very, very, very easy to
Transparent and
get. Yeah, yeah, yeah.
yes. So I basically use that as my, my guide. And then for every bit of the our learning outcome, if it said you need to give a DOPS for it, I made sure there was 2, if not 3. But everything had the minimum number of 2.
Yeah, yeah, definitely. How about the CRS? I mean, like the vision, pressure, and stuff like that. Did you submit 2 or 3 out of them?
No, 2 for everything, and all of those, because they're quite basic competencies. My SAS doctors were happy to sign me off for it. So those kind of things, IOP measurement, those kind of things, I just got it done by my other SAS doctors. So they saw me do it, and then they signed me off for it. So I have a few senior SAS doctors in the trust. So it was they're senior to me, so it was pretty straightforward.
Yeah,
because we ST1s and ST3s in the department, we're all used to signing very basic forms for all of them. So
yeah. Amit is asking if you can share the template. Is that the Excel file, the green, red, and is that another file that you've been using?
I think that's the different one, isn't it? Let me just.
If you're on the WhatsApp groups as well, aren't you? So if you are happy, you can send it on the group if you wish, or you can send it here in the chat. I think you can share a file. I think.
Okay, well, shall I do one thing? I mean, again, my technological capacity is very limited. I'll send it all to you as an email because I have them as an email, and then you have share with the group. I was thinking of trying and sharing my screen, but
you can if you wish, but again, it's up to you. Shall I text you my email address then?
Let me see if I can share my window. But because you're not able to see my camera, I'm not sure if you can see.
So the camera is different, so you can still share a screen. So it doesn't have to do anything with the camera.
Will it not?
Should share. So share and then click screen.
Yeah. Is it coming up?
Not yet.
No, I'm not able to.
Come on, you've done your CESR. You must be very good in IT now.
You would think that, isn't it? That was if anybody asked me what was the most challenging thing, I think the IT bit was the worst for me. Right. Because I'm more a paper person and I like everything with my paper and notes. So actually, to be honest, when I realized that I had to do the Excel thing and everything, I actually spoke to the IT department in the hospital and asked them to send me a training package for Excel. So I did the Excel bit just to make sure I knew how to do it. And then I put it down as evidence in your, you have a thing for IT.
Yeah.
Yep. So I put it down as having done a course on Excel and attached a certificate for it.
Just email me the thing and then I'll just put it on the WhatsApp groups. It's not a big deal. I'm sure it's already there. I'm sure everyone has shared it before. It's the same that Rob shares with everyone. So just to be just to be sure, email it to me or send it on WhatsApp maybe, whichever. Salim, you've got your hand up. You've got a question.
Hi, yeah, thank you, Mustafa and Delicia, for your talk. I was asking about the same, the templates, if you can share it, and we'll have benefit from that. Thank you.
Yeah.
I don't know, what are you seeing? Anything?
Yes, you are sharing now, and we can see you now, actually.
Oh, you can see me. Good. Nice to see you all. Let me share my. Shall I show you the one that I have? Okay.
Because I think you're now sharing your screen. So if you go to the actual sort of table that you want to show us, then
are you able to see it now?
I've opened. Not yet. Not yet.
Oh, why is that?
So just minimize this window. Yeah.
Are you able to see now?
Click this one.
What are you seeing now?
We're just seeing your team's. We're just seeing your team's sort of screen for some reason.
It's just my. I'm not sure why that didn't come up. What are you seeing? You're still seeing me?
Now it's stop sharing now.
Okay, doesn't matter. As I said, I'm not the best with IT. Let me be honest.
That's fine. Just either put it on the chat or send it to me, and then I'll put it on the group. It's not a big deal.
Yeah, I'll send it to you. Yeah.
Fine.
Just give me 1 more second. Let me
Yeah.
see if I'll share it as a window to see.
I thought Indians were very good with IT. That's a bit
Oh,
weird.
I really am.
You must not be pure Indian. It's a bit weird.
I don't know what I am. I'm honestly. I think I'll leave it. Let's not waste people's time.
That's fine. Yusuf, you've got your hand up.
Thank you very much. And you might have mentioned this already. I wasn't on the call from the beginning, but I was just going to ask if is there a list of like necessary courses other than the statutory courses that you have to do for your trust or your appraisal? Is there any list of courses that we have to have done on courses for healthcare or something like that? If you can give us a list.
Delicia, what do you think? Have you done very specific courses that were mandatory from your opinion?
I think the 3 mandatory ones, the train the trainer, the management leadership, and what's the third one? The GCP. So those 3 are mandatory. But then as part of your appraisal, you would have anyway done a lot of courses, and your trust mandatory things, some of them are yearly, some of them are once in 3 years. So if you have a decent appraisal process for the past 5 years, that's fine.
Yeah. Because the TTT, there's many sort of versions of it through the college. So anyone would do. Okay, just pick the cheapest one. All right. There's one for nurses, one for, I think, trainees, one for SAS or something. So just choose whichever. It's just a process that you need to sort of attend. GCP is online. Again, that's easy. I think there's another TTT in Oxford or something. So, and I believe someone has used it before. It should work. How about the management and leadership that you were talking about? So have you done that online?
Yeah, I did the ISC medical. I did the train the trainer course from the college. Because that's quite standardized. But ISC also runs the train the trainers course. So those are the 3 definite ones that we need to do.
Yeah, and Prashov is saying that TTT is available for free. I assume that's the online one, probably? On Future Learn, he's saying. So, yeah, as you can see, there's lots of sources. Yeah.
GCP again was just an online thing that you registered. And because I'd already done it before, it was just a refresher, an e-refresher for me. So those are things that take very little time. If you just factor it into your study days, then it gets done quickly.
Ezra, you've got your hand up.
Thank you. Thanks for the talk. I just want to ask about the mandatory trainings. I don't know why, but our system doesn't give certificate for each and every mandatory training. And when we complete, it just says no, it's okay. And sometimes even in the ESR, I'm not able to find that I complete that thing, but just the email stop about the refresher. So have you had a screenshot of your mandatory trainings to as an evidence, or you put the certificates?
I did a screenshot. Again, we don't do certificates, so I'm not sure about others. But Delicia, have you had a screenshot of your just the green sort of brain, as they call it, or did you actually have certificates for your mandatory training?
Some of them were certificates, and some, of course, you don't get certificates. So every year, as part of our appraisal, we have to show that we are 100% compliant. So you go into your ESR, open your competencies, do the the compulsory competencies, and then it will come up to 100%. You take a screenshot and put it in the appraisal folder. So you just download that and add that on to your list of competencies.
So you don't put any other thing, just when you download your appraisal form, and when they are on that, you don't need to give it as another evidence, and you don't need to put them in another place.
Not really. I mean, I don't know about you, but for my appraisal, what we normally have to do is we have to present a CPD diary, which, I mean, it sounds like diary, but it's basically an A4 sheet with 3 columns. So you have your date and what the courses you have done and how many hours of the courses you've done. So we divided it into external, internal, and mandatory courses kind of thing. So that was part of our appraisal anyway. So every year I have one A4 sheet that tells what I have done. So that bit was already available as part of my appraisal. So I put all those 5 sheets for 5 years. And because for appraisal, when you write them down, there's always a evidence for them. So you always attach the certificate that accompanies it. And for mandatory, instead of a certificate, we normally just attach the screenshot. So that just comes. Is that reasonable?
That should work. I mean,
Yeah,
I've done the same.
Thank you.
I've done the same. So yeah.
Thank you.
Yusuf?
Sorry, again, lots of questions, but
That's fine. That's why we're doing this. Yeah. So just go for it.
I want to ask about referees because I haven't finished my evidence yet, but I thought to give myself a push, I started the application on the GMC website, and it wants you to choose referees at the beginning of the process. Do they have to be? So let's say most of my evidence, if not all of my evidence, is from one trust. Do all my referees come from that trust? And if I end up adding, let's say, something on my logbook from a different trust, but no CBDs, no DOPs, nothing, do I have to get a referee from that trust? And is it a bad idea to just completely omit evidence from a 1 year post I did? I don't want to have to go back there to get evidence. I don't really need the evidence from there. Is that a red flag for when they're looking at your stuff?
Okay, Delicia, can I answer this one if you don't mind?
Yeah, please do.
And then if you disagree with any, just stop me. So basically, referees, the only sort of criteria, they have to be recent. Okay, within the last 3 years, I believe, or 4 years, I can't remember exactly, and minimum now 3. I think it's correct, 3. That's the last thing they said. So 3. In the past, they used to say that one of them has to be the primary referee, has to be the clinical lead. Again, not anymore. So there's some flexibility because they've noticed that actually most of us don't work with the clinical lead, and the leads are not available. They're very busy. They can't be referees, So they were saying someone in a similar supervisory sort of post, So any lead, any senior consultant, basically, your appraiser, maybe something like that. Back to your question. So there's nothing called a red flag. So if you omit evidence from your total hospital, that's fine. It's not a big deal. But you still have to put it obviously in your CV, in your employment, whatever.
Yes.
So that's not a big deal at all. Now, again, let's say you are using evidence from a specific hospital, but you don't have referees from them. That's fine. It doesn't matter. So a referee has to be someone that you've chosen, who you've worked with very closely, and that someone can, say good things about you. That's the most important thing. I'm not aware of someone who got their application rejected because the referee mentioned that, they're rubbish or something. I don't think that's going to be a big deal, but obviously you want someone to write good things about you. Because worst case scenario, they will ask you to do another course or submit more evidence or more training, whichever. You don't want that happening. So basically answering your question, it's not a big deal at all. I don't think that's going to be an issue at all.
Can I add something? I think if you're submitting evidence from another trust, all bits of evidence have to be verified. So you're going to have to find somebody there who's willing to do the verification process. And let me be honest, I mean, this is my opinion, or this is what I was told by some people who are actually college assessors, that the structured reports, which is your references, they form a huge part of your evidence.
I agree.
And somebody has to be invested in you. Those 3 people that you're choosing need to give their time and effort. One, they need to be aware of your practice, so that when they write their reference, they can use all that bit of information as evidence to support your documentation. And they're going to have to spend at least 3 or 4 hours writing that reference for you. And the stronger your referees are, I personally believe it's easier, because when the report from the college, from the GMC finally came, you can see basically they've cut pasted your referee reports to kind of say this particular person has said da 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 this about Delicia, and is a strong evidence towards her meeting the criteria. So in my opinion, when you start your CESR process, be sure who your referees are going to be, have that conversation early on. And for me, the referees also helped, because they helped to set up some of the clinics, because these are consultants, they're senior consultants, they've been in the unit, and they all have a little bit of clout. So, getting things done is easier when you have friends helping you.
I agree. The verifier is much easier. A verifier is just someone, I think, has to be a consultant. I don't think a non-consultant can be a verifier, although I'm not entirely sure, so people can sort of confirm that. Someone you don't have to have personally worked with in person, because they're not commenting on anything. They just reply to the email saying, okay, yes, his evidence is correct. Yes, I'm happy to be his verifier, and that's it. Yeah, so it's a bit different. So the verifiers,
I think I confused the verifiers and the referees. Yes, now it makes sense.
Yeah,
sorry.
A verifier, you have to get a verifier from each hospital that you're getting evidence from. That's out of the question. No verifier, no evidence.
Yes.
And actually, you need to have the verifier. You need to show them the evidence before you even submit. And surprisingly, what happened for me was, because they said, I'd done all the 4 or 5 subspecialties from the university hospital. And they basically said, because most of it, all of that was kind of less, and all the other evidence was from just one trust, they didn't ask for they didn't ask for the verifier from the university hospital that I went. They were just happy with the reference from there, and which was very strange. I thought that I had to submit them when I submitted the application, but they never contacted the verifier, because they said the amount of evidence from that particular trust was very little.
Okay.
Can I ask
that's
one
an
more
exception,
question?
okay? So, but yeah. Okay,
yes,
fine.
I know it is an exception. That's why I did say that you need to have a verifier for every bit of evidence.
For referees, one last question: Can one of the referees be a consultant who is actually on the specialist register from Europe, who didn't go through UK training?
I don't think it matters, does it?
I think it should be fine. It's a referee. Remember, a referee is just someone that you've worked with. Okay, that's the main thing. That is someone who can comment on your performance. Because remember, lots of people who can do CESR outside of the UK. Yeah, so they're working with people who are not even GMC registered or never been to the UK. So I don't think that's going to be a big deal.
Thank you.
Yeah. Amit, you've got your hand up.
Hi, Mustafa. Hi, Delicia.
Hi.
Yeah, my question is regarding the referees only. We have to choose 3 referees, and one of the referees has to be the primary referee, right? So, they have written on the GMC website that this primary referee has to be from the current place of work.
That is correct. Yeah.
So if most of our evidence is from the previous place of work, we cannot choose them as a primary referee.
No, you can't. So what happened to me, let me tell you an example. So what happened to me is from my previous trust, when I actually submitted my evidence, that's okay. So that's 0 hours. Okay, I submitted, and then it took months with the GMC back and forth, chasing up the verifiers, the referees. The primary referee did not reply. Okay, he's a very busy guy. He's the lead, not very busy. And then they kept chasing him up, no replies. And then she was like, that's the GMC advisor. Okay, just ignore that referee, get your current referee, because now it's too late now. Now you've moved jobs, you're now in a new place, then ideally it should be a current, someone who's working in the current place that you're working in. So back to your question, primary referee should be someone in your current trust. Okay, does not necessarily have to be the lead, although some advisors would reply saying, please get the lead to do this. I think there is some leeway. You can just explain to them that this, just by email, that this lead is not approachable. He's very busy. He doesn't reply to emails, whatever. And I think it will be fine to get someone else. But it has to be someone in your current trust.
Okay.
Any
I
other
think
questions? Yeah.
I think somebody has asked which university hospital it is. It's the Nottingham University Hospital, Queen's Medical Centre. Yeah, oh, you've answered that. Thank you.
Yeah. And so you would suggest Nottingham as a place that supports CESR then?
I think I mean they were okay with me, and I'm sure they have a few doctors within their trust trying to get hold of CESR. But I also have a feeling that a lot of the conversations we have is just around the the work-based assessments and the evidence. There's so much more in the application. I'm not sure whether people work towards that, or is that a weak area, or because
Like
we
what?
hardly
What do you mean? What
like
other weak things?
like the management. How are you going to, your teaching, your audit, your presentation, publication? So there's lots more to this evidence than just the clinical assessment. That just forms one part of the assessment.
Yes. I
So
always find that that's the old curriculum we're talking about. So the first half of the curriculum, these are the clinical stuff. Let's call it the clinical. So the CRS, the DOPS, the OSATs, these sort of things, the CBDs. These are things that we do actually in clinical life. The first maybe 100 outcomes, but the second sort of 80 or something, these are the vague stuff. So from HPDP or IH, can't remember, and then forwards, all of these things are very vague, and people are not sure how to fulfill them. The outcomes are very vague. So would you agree that these sort of outcomes can be flexibly signed off by either a CBD or a course or, whatever? So let's say something like, safeguarding, for example. How did you sign off safeguarding?
Yeah, safeguarding is part. I mean, if you're doing eye casualty, you will see safeguarding. I mean, you're definitely going to examine one baby with an NAI. So that's safeguarding.
A
And
CBD.
then a CBD, yes, a CBD, and that forms part of your logbook as well, isn't it?
Yeah.
So that would be a safeguarding. I had a child who present, so I did one NAI safeguarding like that, and I had another child present to eye casualty with an unexplained subconjunctival hemorrhage. The story that the mum was giving, he was a 3-year-old. I ended up doing a MASH referral for the child, and did another CBD on it. So
interesting. But yeah, CBDs are very important actually. CBDs, they and you can associate it to 3 outcomes. So you need to have CBDs. Did they specifically ask you to sign off, get 10 CBDs per specialty, or?
I think that's the number we were kind of working towards. So that gives you ability to then, because you know what outcomes you want, and then you then kind of plan, okay, for this particular outcome, this is how I'm going to show the evidence. And then your additional evidence for safeguarding will be attending your level 2 safeguarding course or level 1, whatever your trust offers you. So you put that as your additional evidence. I think that's why I was wanting to show my, the completed.
So until she shares her screen. So yeah, so basically the second half, it's either a mix of CBDs, mandatory courses in your trust, external courses that you've done, reflections. Have you done reflections?
Yes, I had to do a reflective diary, isn't it?
Yeah.
So I did a reflective diary, and because the appraisal process in our trust is quite a robust one, for every course you attend, we were expected to do a learning and reflection. So I did reflective diary after I collected all the evidence. In the last 6 months, I opened a Word document, cut, paste all the reflections of 5 years worth of CPD, whatever reflection I'd done, I cut, pasted it, used a little bit of ChatGPT to make it look a little bit nicer. And so that was all my CPD. I had subheadings for my reflective diary. So CPD was one. I had a complaint for which I'd responded. So I put that in. And then the datexes that I had filed. So I had a collection of them and then put a little reflection for each one of them. And then I'd done a bit of management activity. So I put that in as well. So it was basically about a 20-page document, which I called a reflective diary.
Very nice. Very important, actually. Very important. Again, I found it sort of a bit tricky to sign off some outcomes, and then I just decided to let's just do a reflection on them, and then again a Word document, and then maybe half a page worth or something of that particular outcome, maybe a case that you've seen and you've learned something about it, and then you can associate that particular outcome to that case in that reflective diary. So it works. It's a relatively easy way that you can get something signed off without chasing someone else to sign you off for something, or so it's not that bad. Bina, you've got your hand up.
Oh, hello, Mustafa. I have a query. Delicia, can you please share a template for the reflection? And do we segregate the reflections according to the specialty like cornea, glaucoma? And is there a number of reflections we have to do for each subspecialty?
No, Beena, it doesn't work like that. Basically, as I said, it was a Word document of about 15, 16 pages. I'll just get to it so I can, I'll just tell you so I made it like a book. So the first page was contents. So
Yes.
I then put the first, let it just load up, and then I'll tell you what it was. So CPD was my first. Then second was attendance at LVA clinic and my site awareness training. So I did a 1-page write-up about what I learned in that clinic. Then the third was complaints and compliments. That was literally one complaint. Then colleague and patient feedback. Again, as part of your appraisal, you do a reflection for MSF. So I had 3 MSFs over 5 years. So whatever I put in my appraisal, I cut, copied, pasted it. And then the DATIX incidents reported by me, there were 4 in the last 4 years. So I did a little write-up. What was the outcome of it? So I wrote that up. Then management experience, I did a little project on PIFU, so I wrote that up. Then I attended the management course, so I wrote that up, a reflection on that course. And then I wrote 2 challenging cataract cases. So again, an A4 sheet for each case. And that was it. So it came up to about 7 subheadings.
Yeah, because it's very there's no, people always keep asking, are there anything specific that I need to get done? Is there any special number? It's not like that, it doesn't work like that. It's reflections, it's a reflective practice. We really like reflective practice in the UK. So it's whatever you've learned in any specific scenario or case or course, whatever, and then you just write your thoughts. That's why if she's happy to share her reflective diary, that's fine, but it's not going to work for everyone. It's it's your own thoughts. It's there's no specific thing about it. Yeah, so just think about things that you've learned, okay, and be very honest with them. It doesn't matter if you've done a big mistake. Let's say you've done a really big mistake. There's no point in hiding mistakes. So again, they want to know that you've learned things. Yeah. Again, another very good example is the cataract complications. Yeah. So let's say you've done let's say you've put a wrong IOL in. Yeah, that's a complication. It's an every event. So write a reflection about it. You can associate it to being honest, probity, to the patient, those sort of things. It's always an opportunity. Okay. Let's say that you're the best surgeon ever. You've never done a mistake. You've never had a complaint. Then make them up. Okay, so you have to write down a simulated complaint or a simulated, complication that you've had to deal with and what you've learned from it. Yusuf is asking, is that the same as reflecting on every PCR you get or recurrent detachments if you do VR? You don't have to reflect on every single PCR. Yeah. I hope you don't have many. You're a VR surgeon. I'm sure you haven't got many PCRs, but yeah. So not many. So I've put like 5 in that complications audit. Again, what happened? What did you learn from it? Could be something simple as CMO or Desmet's detachment or something, or PCR, obviously. Whatever complication that you've had, just pick a few and write what you've learned from the cases. You don't have to put everything, not at all. Okay. Again, siding from that, let's ask Delicia about her cataract audit. So tell us what you've done about your cataract audit.
Cataract audit, I think a few months ago, or probably a year or so ago, there was link that was posted in our in our group actually of a done cataract audit. I don't know, you probably have it. And I remember saving it and keeping it. So all I did was, because we have micro Medisite in our hospital for cataract, so you choose your 50 cases. I think I did about 80 cases in 2023. So in that year, took 50 cases, consecutive cases, and then all the graphs and everything was done. And I just cut, copy, pasted it, and then wrote it all according to how the audit needs to be, submitted. So it gives you what are your standards that you're looking at. So there's six standards that you need to look at. It was shared in our group, and I just followed it.
It's a template that the college has put down. So you just have to change the names and numbers and stuff like that.
Change the names, numbers, and it tells you your outcomes come from your Medisite data. So it was pretty straightforward. It took me a weekend, literally just a Saturday and Sunday to do it.
Again, I'm not sure about anyone who have done their cataract audit and they've put down their, complication rate as very high and they had issues with it. Obviously, it would be smart to choose your good cases, so 50 cases still consecutive, but do not pick the ones that you've sort of, mucked up, just choose the ones that you've done well and just do an audit on them. Yeah. I'm sure all of us will not have a very high complication rate. That's not going to happen, but I'm assuming that even if that's the case, it's not going to be a big deal. Then do a reflection about it, say that you've taken more courses, or maybe you've sort of stepped back a bit, starting to do less complex cases and then building up more numbers, whatever. So, cataract audit template, we will share it on the group. Okay, so
I think I took it from the group. I literally did it, verbatim from that. Just gave my numbers instead of what was written there. For me, I think I had a very high rate of complex cases. I mean, out of the 50 cases, 10 of them were white cataracts, because they were all the cases that had been, delayed presentation post-COVID. And plus, I'm sure all of you know that the cataracts we are getting in the hospitals are really bad ones. So I did have quite a high number of complex cataracts.
How about your PCR rates? How much were those?
Luckily, of that 50, I didn't have any.
What? I don't believe that. I don't believe that.
No, I did have quite a low rate anyway. I think mine is 0.98 as per Medisite, so I'm not bad at all. So I did have to submit that for that, the 50 that I chose, there was fine. There was not a single PCR in them. But overall, the rate was 0.98, so it was not
nice.
bad at all.
Bina?
Yes, one query about the cataract audit. The post-operatively, we send our patients to the opticians for post-op refraction. Do we need to include that data as well in the audit?
Bina,
post-op refraction?
In my trust, we do have an option of bringing patients back to us or to send it to the optician. So we either say clinic review or community review. And once I started my CESR process, I brought all my patients back for a clinic review. And they were, I made sure they were all seen by our specialist nurses in clinics. So I had the post-op data. So I do have that flexibility in my trust, but I'm not sure.
Yeah, you're lucky. You're lucky. I mean, lots of managers will not be happy with that, and lots of cataract leads. They will just ask you, why are you bringing all back the patients? That's a big load on the clinic, and certainly most places would have the same issue. They're not happy to see sort of straightforward cataracts. So again, let me tell you what I've done, and it worked. So yes, there are consecutive patients, but because of that reason, again, we discharged patients. We did not bring them back. I tried to, but again, it wasn't easy to bring them back. So I involved more than 50 cases. Yeah, and I've put down like maybe 100 cases in my audit, and then I've written down that because not many patients have got their post-op outcomes, so I had to exclude about 50 cases, and still took my 50 consecutive cases, but not actually consecutive, but with lots of patients removed because of the missing data, and it worked. Okay. Another option, which others have done, and I've seen trainees do that as well, is that they call the patients, so and they're opticians, so can you please give me the data, or maybe give a form to the patient after you're done with them, and then the optician can fill it out and send it to you. So there's lots of options, but certainly my way worked, and I found it the easiest, it's just to involve more patients, and just write down that you had to exclude those few because there is no data. Salim.
Yeah, so my question is cataract audit a must? And secondly, is it apart from the other 3 audits that we have to do with one complete cycle? So is it a 4th one?
Yeah,
definitely. Yeah,
definitely, yes.
Definitely important. And it's not included in the 3. Yeah, so the cataract audit is separate.
I think the number of audits are dependent on the number of years since your last revalidation. 1 per year since your last revalidation, but if you've been revalidated in the last year, you need a minimum of 3 audits.
Yeah.
If you are struggling with audits, another good one to pick up would be the trust will do trust-wide audits. There are a couple of, I don't know about other trusts, but every trust should do a medical record keeping audit. They should do a consent audit. These are good for re-auditing. I don't know, are people aware of this? That the trust, there are trust-wise audits. So all you have to do is go speak to your audit lead and say for the next year or so that you will fill in data for these trust-wide leads. The forms are already made out. So you just enter patient data. Technically, it's 30 patients every month or so. If you want, you can, and it literally takes 10-15 minutes to do a medical record keeping or a.
So that's not in, is that in ophthalmology?
Yeah. It's ophthalmology. So at least our trust had it. And I was doing the trust medical record keeping audit for nearly 10 years. So that was always there. And because I needed a quick turnaround of, like a re-audit. So our numbers weren't great. Then we introduced some stamps for our doctors, but this was before we went into electronic patient records. In the last 18 months, we've moved on to electronic patient records, but this was something. The other could be consent, and that you did a teaching on consent and people's way of filling consent forms got better. So that's again a quick cycle because you collect data every month. You can then say you did a teaching in one of your clinical governance meetings regarding how to do consent forms properly. And then 2-3 months later, do another collection of data. And then you can show that the percentage has improved. And this is the easiest way to get a repeat audit done very quickly.
Very good idea, actually. I wasn't aware of that. No, well done. Again, let me
Thanks, that's useful. Thank you.
Yeah, and let me again about audits, ask the question and answer it back. So the audits, as you were saying, that one opinion is saying that you need 1 per year since the last revalidation. Certainly, Rob has mentioned that at some point. Another opinion says that you need to have 1 every year. So for every year worth of evidence that you're getting has to be 1. Debatable. Another saying was has to be 1 from each specialty. So different specialties. Was that the case with your application?
For me, yes, because 2 of my audits were medical retina because I submitted 1 from 2019, though most of my evidence was 2022 onwards to make up the number of 5 because I wanted to be a little bit more than what was necessary. So I had 1 from 2019, a medical retina audit, and all I had from it was just a certificate from the audit department. So I submitted it. But for the other audits, I had the reports, I had the presentations. Another was an MR audit. I did a cornea audit on infectious keratitis. And then the trust record keeping audit was there. And then I did a management one on patient initiated follow-up. So I presented that as an audit. And again, I had 3 years worth of data for it. So that came as, so I had 2 completed cycles of audit.
Oh, nice. You just need 1, but she was on the safer side. So
I was quite lucky with the management bit of it. Nice. So
and again, the full cycle, you don't have to do A to Z, by the way. Yeah. So the full cycle, you can get an old audit and then just re-audit it. Okay, and that will work. Okay, I'm certain of that. So it is a bit flexible. And let's agree. I'm sure Delicia will agree as well that what worked for her might not work for me. Okay, and it really depends on the assessor. Okay, my assessors were nice, you know, and they were a bit flexible. Maybe they thought that my other evidence was good, so my audits actually weren't great. Yeah, but it worked. That's actually my weakest point, the audits, but it worked because maybe the other evidence was okay. Maybe her assessor was much more tough, and you know, I certainly know people, you know, who got very good applications but still got lots of recommendations. So it really will depend on the assessor, you know. So the guidance is a guidance, it's just a guide. And what we're doing here is that we're taking lots of different experiences, but as you can see, there's lots of variability. Yeah, so it will be on your whole application and your whole experience, and more importantly, the assessor as well. Yeah. Um, Fine. Has anyone got any other questions? Think, Arshad, Omara, you've got your hand up.
Hi, Mustafa. Hi.
Hi.
Hi, Delicia. I just wanted to check, is the QI is something could be considered as audit requirement, QI as well, and you can complete the cycle as a loop to finish up one loop of, okay.
Yes.
All right.
Yes. For us,
Okay.
the PIFU was a quality improvement program. When the government introduced PIFU, we introduced it in our trust. And then we looked at, you know, what the outcomes were, and we did it. So it was not a real audit per se. It was a quality improvement program. Yeah.
Okay. Thank you.
Equip was accepted. I think what I mean, getting the work-based assessments and the clinical assessments were easy. For me, it was building up the rest of the portfolio, which I thought needed a lot more work. I don't know how everybody else feels about it, getting the teaching feedback and, you know, those kind of things. I seem to spend.
I agree, because the forms are, you know, we know the forms, and it's the easiest thing actually is to get something signed off, you know, but to get the other sort of vague stuff is challenging. But the rule is, as she mentioned, you need to go through all the outcomes, make sure that you've covered everything, especially the old curriculum. Okay, so if you're applying through the old one until June or July next year, make sure that you've covered everything, and it has to be 2 pieces of evidence for each outcome. Okay, and the things that are they've got a specific form, like a DOPS or an OSATs or a CRS, has to be 2 of these forms. Okay, it wouldn't work if you've got a CBD and a DOPS for that thing. A BCL, inserting a BCL, you cannot sign it off with a CBD. Okay, has to be the DOPS for BCL. That's the rule. All right.
And I think the other thing I wanted to mention was, apart from those 3 mandatory courses, attending a cadaveric course, that's a lot of signing off done. You know, within 48 hours, so many of your forms are done, and those course organizers know that you're coming to have those forms done. So everything was done within a weekend. I did the Coventry cadaveric course, so I would strongly recommend that. The only other thing I wanted to say was, now the new application has those 12 subheadings, isn't it? Your CV, your work-based
domains, yeah.
The 12 domains, yeah. So what I did for communication, partnership, and teamwork was, I approached the clinical governance team, did an SOP writing. So there's always work in the department to do. So pick up those things, and then those last 30, 40 outcomes that Mustafa was mentioning, it's easy when you have done those kind of work. When new doctors join the trust, try and do an induction for them. You know, put yourself up forward for it. If there's some kind of an interview happening, tell them you want to be an observer on the interview panel. People are just happy to let you sit for all this. But this kind of builds up your portfolio in a nice way, to say that you've been involved in management and governance activities, and helps you to build up a, you know, just apart from the clinical assessments, you can build up quite a strong application. To be honest, I didn't have refraction, because all I had was my MRC off from many, many years ago. I just didn't get an opportunity to refract kids or do the retinoscopy at all. So of all my 180 outcomes, those, I just didn't have any piece of evidence for that. And the other one that I didn't have was a patient enucleation. I only had a patient evisceration, but I had unique enucleation in cadavers.
So back to the refraction. So you didn't have to submit
I didn't
any
have a DOPS or anything. Yes.
That's very weird. So
It is weird, I know.
how about the exam? I mean, the refraction exam. You haven't done the refraction exam.
Well, I did it as a part of the MRC off. That was back in 2008, and I just had the FRC off. So what I mean is they look at your application as a whole, I think. And
Yes.
if you're pretty strong in some other areas, they kind of realize at the end of the day, it's a box ticking exercise. It's a game to be played. You put your head down, play the game, get it done in the shortest period of time possible. So you can actually go and concentrate on your clinical practice. I think for me, taking away 18 months to 24 months away from my subspecialty was the biggest problem, because I was going and doing stuff that was useless for me.
Yeah, and very out of your comfort zone as well, so you found yourself in a neuro clinic, so why am I here, so
and it's nice. I mean, the general learning of knowledge and all is, but it's a very painful process. So try and keep it short, do it quickly, get out and actually do what really matters to you guys.
Yeah. So it's definitely worth it at the end. Definitely worth the effort. Definitely.
Totally.
Yeah. Thank you very much, Delicia. That's been very useful. I think that's one of the best ones that we've done. So thank you very much. I'm sure everyone would appreciate.
You say that to everyone, don't you, Mustafa?
No, I don't. You're special.
Oh, thank you. That makes me feel good. All the best to everyone. If there's any way I can
Thank you,
help,
both of you.
please.
Thanks, both of you.
Thank you, both of you.
Thank you. If there's anything I can help, you've all got my number.
Thanks a lot. Thank you both.
Contact me.
Thanks, guys. I will put the recording on YouTube today, hopefully. Okay. Yeah. All the best. Take care.
Thank you. Bye-bye.
Bye.
Bye-bye.